So why is intraocular pressure measurement important in the pediatric population? While the diagnosis of primary congenital glaucoma is fairly obvious, we need to rely on intraocular pressure measurements to both diagnose and manage glaucoma in patients with glaucoma associated with other ocular anomalies or syndromes, in all children who are aphakic or pseudophakic following ocular trauma, and juvenile glaucoma as well. And we also need to rely more on intraocular pressure measurements in this age group because there is a difficulty in optic-disc evaluation, in documentation, and in visual field estimation. But there are certain challenges in IOP measurement in this age group: the presence of corneal scarring, the abnormal corneal size and contour, hysteresis, as well as the presence of nystagmus, which is found in a large proportion of this population. There are a lot of difficulties in interpretation of results from various pediatric studies because of the variation in the populations studied with regard to glaucoma, the postoperative status, different reference standards used. Many of the instruments were used in non-randomized order. There was non-masking of observer, and there were variations of techniques in anesthesia which will affect the IOP measurements. These are the popular instruments used in the pediatric population: the GAT, the Perkins, Tonopen, NCT, rebound tonometer, and a few with the ORA. While children older than 5 years of age are usually cooperative for measurements with the GAT using topical anesthesia, most often we need to either sedate them or perform examination under anesthesia. But we need to know the effects of general anesthesia on the IOP measurements. And this study, in which 30 children were randomized to receive either inhalation anesthesia with sevoflurane or intramuscular injection of ketamine, it was found that sevoflurane caused a significant drop in intraocular pressure, starting 2 minutes, going on for 8 minutes following induction. So it is important to take IOP measurements as soon as the child becomes quiet. Pre-medication imidazolum is commonly used now, and in this group, before administering imidazolum, IOP was checked, and it was checked every 15 minutes for 30 minutes after administering imidazolum, and then again after anesthesia was induced with propofol. And you can see that with imidazolum, it was fairly stable throughout, and after induction, it dropped significantly. So imidazolum doesn't really affect the IOPs. A laryngeal mask insertion is often used to facilitate UA in children. And this study found that there is a significant elevation of intraocular pressure when you introduce an LMA. Therefore, it is important to check the IOP before the insertion. Some of the most common instruments used for IOP measurement are the Tonopen and GAT in children. And this was a large study which looked at the differences in both office measurements as well as measurements under general anesthesia. The Tonopen underestimated intraocular pressure when the IOP was less than 10 and overestimated by almost 3 millimeters when the IOP was more than 20. And this difference increased with the younger age group. And thickness of the cornea did influence measurements with both the GATT and the Tonopen. So as Dr. Ronnie had told us, the eye care tonometry has become much more popular than the other instruments now in examining children. And this was a report which looked at the eye care tonometry in children known and suspected glaucoma. The eye care IOP was within 3 millimeters of mercury of the GAT in about 63% of children examined. And however, the eye care IOP was slightly more than the GAT in 75% by about 2 millimeters. This was a study which compared the rebound tonometer with NCT. Successful IOP measurements were possible in almost 90% using the rebound tonometer compared to 72% using the NCT. And the rebound tonometer measurements were slightly less than the NCT, varied by about 0.9 to 1.8 millimeters mercury. So this was a comparison which looked at the handheld rebound tonometry with GAT in patients with glaucoma. It was found that the limits of agreement varied between -6 to about +6. The rebound tonometry recordings were higher, but the rebound tonometer was the preferred method by the children in about 70%. What are the factors which affect IOP measurement in children? Since an eyelid speculum is often used when performing an examination under anesthesia, we have to remember that it may cause an elevation of intraocular pressure, as seen here in this group of 77 eyes of 45 children who were examined. There is a significant increase in IOP, and therefore it's better to measure it before applying the eyelid speculum. There is also evidence to show that central corneal thickness does affect IOP measurements in children as well. And this is important because there are various reports in our experience as well that the central corneal thickness increases significantly following in aphakic eyes. So this will make a difference when you measure IOP in this population. And the increase in IOP with increase in central corneal thickness was found to be more with the rebound tonometer than with the GAT. Corneal hysteresis is another factor which we have to keep in account, especially in patients with congenital glaucoma. And this group looked at the 91 normal eyes and compared to 11 eyes with congenital glaucoma and found that the corneal hysteresis was significantly less in patients with glaucoma, and this will influence our IOP measurements. They also found that the corneal composite intraocular pressure was much higher than that of the golden tonometer in this group. There was another study which looked at the IOP associations with refractive error and axial length in school-going children and found that there was no significant influence of these factors. So in conclusion, the ideal instrument in children should be easy to use, should be accurate, and should give you reproducible measurements. The GAT remains the gold standard. The tonopen and the rebound tonometer is useful in estimation. Children prefer them to the other methods. However, elevated IOP, which has been discovered with these instruments, needs to be reconfirmed with the GAT. The effects of corneal pathology on hysteresis and central corneal thickness and the effects on intraocular pressure measurement have to be accounted for in children as well. You also need to keep into account the measurement artifacts produced by external influences, as I had already discussed. And most important of all, keep in mind the influence of the anesthetic agents when assessing under general anesthesia. Thank you.